In our last few sketches, we went over the myeloid neoplasms, cancers that derive from myeloid progenitor cells. These are stem cells in the bone marrow that give rise to the myeloid cell lineage, which includes red blood cells, megakaryocytes, which make platelets, monocytes, and granulocytes, such as neutrophils, eosinophils, and basophils. Well, forget it. Clear your mind, because we're moving on to the lymphoid cell line. That means B cells and T cells, friends. This sketch is the first in our series on the lymphoid neoplasms, and we're starting with acute and chronic lymphoid leukemia. Now, I know that you're thinking, hey, whoa there. That says leukemia and lymphoma. There's something you're not telling me here. I thought we trusted each other. I want my key back. Okay, first of all, you're overreacting. And you know what? I feel like we need to set some kind of boundaries in our relationship here. This is getting a little too serious for me. Now, about that whole leukemia-lymphoma thing. You're right. Turns out, the B and T cell neoplasms we're about to cover can present both as a leukemia or as a lymphoma. These are just general terms for where in the body these neoplastic B and T cells are setting up shop. In the case of a lymphoid leukemia, neoplastic lymphoid cells take over the bone marrow and cause cancer cells to leak out into the peripheral circulation. This is represented by the royal banner, which shows a cancer crab in the marrow sending malignant cells into the blood. Contrast this with lymphoma, which at Sketchy we symbolize with a chessboard overloaded with chess pieces. The board represents a lymph node, and that accumulation of white T cell knights and B cell archers is meant to evoke an image of abnormally proliferating lymphocytes in that area. You see, in the case of lymphoma, neoplastic lymphoid cells form a tumor in a lymphoid organ outside of the bone marrow, such as the lymph nodes and spleen. Unfortunately, it gets even more complicated, because leukemias can present in the lymph nodes and look like lymphoma, while lymphomas can take over the bone marrow and present like leukemias. So, by the power vested in me, I officially give you permission to stop worrying about whether it's technically a leukemia or a lymphoma. I'll get back to this definition a little later on. What's most important for you to know is not where the cell came from, but what kind of cell it is. Just like in the myeloid leukemias sketch, we'll be dividing the lymphoid neoplasms into both acute and chronic forms. Starting with acute. Acute lymphoblastic leukemia lymphoma, which we'll shorten to ALL, is going to be illustrated out in the courtyard of the castle. Think of these children as immature lymphoid cells, honing their skills before they join the ranks of the leukocyte army. Recall that the lymphoid lineage includes B cells, represented by an antibody archer, and T cells, embodied by the knight in training with a T-shaped sword. The fact that they're all kids is important. This is acute lymphoblastic leukemia lymphoma, not lymphocytic. That's right, we are not making mature lymphocytes here. ALL is caused by a somatic mutation in a B cell or T cell precursor. Differentiation halts at an immature lymphoblast stage, before these cells start proliferating out of control. These fledgling knights are also here to remind you that ALL is the most common cancer in children, with a peak incidence between 2 to 5 years of age. Then here's a little 3-year-old. Still too young to train, but cheers on his comrades nonetheless. While the majority of ALL cases occur in children with no other known medical conditions, Down syndrome is associated with a 10 to 20-fold increase in risk. 1 to 3% of ALL cases, in fact, are attributable to Down syndrome, symbolized here by the downtown label marking the planned location for the new Winterfell city center. As you might remember from our last sketch, Down syndrome also increases the risk of acute myeloid leukemia, or AML. All right, there are 2 categories of ALL that we're going to cover, the B-cell variety and the T-cell variety. See that bone quiver worn by the fledgling B-cell archer? Precursor B cells are derived from and begin to mature in the bone marrow. So, this is where a mutation occurs in a pre-B cell to cause B-cell acute lymphoblastic leukemia, or B-cell ALL. B-cell ALL is actually the most common form of ALL, making up about 80% of cases. T cells are also derived from the marrow, but they mature in the thymus. It's where they train, if you will. So, in this sketch, T-cell training is occurring in the thyme garden. That's time for thymus. It's here, in the thymus, that a mutation occurs in a pre-T cell to cause T-cell acute lymphoblastic leukemia, or T-cell ALL. T-cell ALL is less common than B-cell ALL, and accounts for around 15 to 17% of cases. Also, T-cell ALL usually occurs in male teenagers between the ages of 15 and 20. So notice that we've made this precursor white knight a strapping young teenager. Regardless of whether the neoplasm results from a mutated B-cell precursor in the marrow or a mutated T-cell precursor in the thymus, you need to see a specific cell type if you're going to make the diagnosis. And that's lymphoblasts. Lymphoblasts are one of the earliest stages of lymphocyte development. And in a normal, healthy individual, you should not see these things floating around outside of the marrow. Let's emphasize that blast suffix at the front gate, where the enemy seems to have launched a surprise blast attack. So we have a blast. Let's say we found one on a peripheral blood smear. Blasts out in the periphery? Not cool. But how do we know it's a blast of lymphoid origin and not myeloid? Well, for starters, they look a little different with a right Giemsa stain. Like myeloblasts, lymphoblasts are often large with big nuclei, but this time the chromatin is coarse and clumped and the cytoplasm is scant. Pretty much looks like all nucleus. We've depicted this big purple nucleus on the shield there, but this isn't good enough. In reality, lymphoblasts can be small or large and have more or less cytoplasm. What else can we look for? I know. No hour rods this time, that's for sure. Remember those from the myeloid sketch? Hour rods are for granulocyte precursors only. And look at all that granulation. That's also indicative of a granulocyte precursor, not a lymphoid cell. I'm still not convinced, though. Another helpful way to distinguish lymphoblasts from myeloblasts is to look for the presence of glycogen in the cytoplasm, which causes the lymphoblast to stain positive for periodic acid Schiff. PAS stain is represented by the frisbee. Think of passing a PAS frisbee. Lymphoblasts will also be positive for terminal deoxynucleotidal transferase, or TDT, which is present in all immature lymphocytes. Myeloblasts, on the other hand, are TDT negative. TDT actually plays a role in antibody formation. It's responsible for adding nucleotides to the V, D, and J regions of the antibody gene. VDJ recombination occurs in developing lymphocytes and is responsible for creating the diverse array of antibodies and T-cell receptors that are crucial for the function of the immune system. Okay, so you can differentiate a lymphoblast from a myeloblast. Whoop-de-doo. Let's focus now on how to figure out whether it's a B-cell or T-cell lymphoblast specifically. For that, we need to look at the cluster of differentiation molecules, commonly known as the CD numbers. Here's a super easy way to distinguish between the two. Basically, any CD number below 10 marks a T-cell, whereas CD numbers greater than 10 generally point to B-cells. This is illustrated on the ground next to the T-cell knight in training. Recall that mature T-cells are either CD4 or CD8 positive. Well, their immature T-cell precursors are positive for both. In addition, pre-T lymphoblasts also display CD2, CD3, CD5, and CD7. 2, 3, 4, 5, 7, 8, launch. Practice that footwork. Contrast this with the pre-B-cell markers, which are up on the archery target. That's CD10, CD19, and CD20. Gotta get that 20-point bullseye. All right. Now that you know whether it's a B-cell lymphoblast or T-cell lymphoblast sneaking around in your patient, there's one more question you need to ask. Where did it come from? In other words, is it an acute lymphoblastic leukemia or lymphoma? Yeah, I'm bringing that up again, but I'm going to keep the definition simple. If blasts are found proliferating and taking over the bone marrow, you call it a leukemia. And technically, when I say taking over the bone marrow, I mean that blast forms take up more than 25% of the marrow. Notice the subtle 25 design we've incorporated into that gate. It doesn't matter if these are T lymphoblasts or B lymphoblasts. If 25% of the marrow is affected, you can officially call it a leukemia. The B-cell type particularly likes to present this way, which makes sense because this is where B-cells are born. In that case, you'd call it an acute B-cell lymphoblastic leukemia. We've put blasts inside and outside the gate to remind you that blast forms are leaking out into the circulation, where they're usually first noticed on a blood smear before a bone marrow biopsy is obtained for confirmation. When should I call it a lymphoma instead of a leukemia? Well, these neoplastic B and T cell lymphoblasts like to travel to various lymphoid organs throughout the body. In fact, they particularly like to form masses in the lymph nodes and thymus. But just because you find a mass doesn't mean it's a lymphoma per se. It all goes back to the marrow. Regardless of whether these form a peripheral mass, if you have over 25% marrow involvement, call it a leukemia. Strictly speaking, if you want to call it a lymphoma, this means that there are less than 25% blasts in the marrow, along with a mass lesion forming in the periphery somewhere. It turns out that the T cell type particularly likes to present this way, often as a mass in the thymus and normal marrow. In this case, we call it an acute T lymphoblastic lymphoma. A mediastinal mass makes sense because this is where T cells go to mature. So why not throw a temper tantrum right inside the thymus while you're at it? So remember to look for that large anterior mediastinal mass, just like the one we've placed on the practice dummy being used by the T cell knights in training. T lymphoblasts also like to form masses in the lymph nodes, especially in the cervical, supraclavicular, and axillary regions. When it's a thymus mass, watch out, because other structures in the mediastinum can get compressed, resulting in superior vena cava syndrome, respiratory symptoms such as stridor and dyspnea if the trachea is involved, and dysphagia from esophageal compression. Remember though, mass or not, with lymphoblastic leukemia lymphoma, if there's 25% bone marrow invasion, it's leukemia time. Speaking of, let's talk about how the leukemic version presents. First, keep in mind that the acute leukemias have an abrupt onset. Being acute and all. Now, as the bone marrow gets filled with lymphoblasts, this doesn't leave any room for the production of mature lymphoid or myeloid cells. So patients with acute lymphoblastic leukemia can present with anemia, thrombocytopenia, and neutropenia. To simplify this, we've included our symbol for pancytopenia, an empty pan next to the royal cook who's tired of serving these ravenous and ungrateful kids. Clinically, patients usually present with fatigue due to the anemia, easy bruising or bleeding due to the thrombocytopenia, and fever, which can be due to infection in the setting of neutropenia or just due to the leukemia itself. Keep in mind that in acute lymphoblastic leukemia, blasts are starting to flood the peripheral circulation as well, causing a high white blood cell count on labs, leukocytosis in other words, represented by the excess of white doves. These lymphoblasts are, of course, non-functional, and the patient truly has a functional pancytopenia. Don't be tricked by all those blasts. Like we mentioned earlier, lymphoblasts like to go everywhere lymph goes. This means leukemic cells can infiltrate the lymph nodes, liver, and spleen, causing generalized lymphadenopathy and hepatosplenomegaly. This is represented here by the lymph node ornaments, hepatic oat bag, and splenic saddle. Due to the expanding marrow in the bone, as well as infiltration of the periosteum, acute lymphoblastic leukemia can also cause bone pain and tenderness. So, never stand behind a horse. Everyone knows that. Like other cancers, leukemic cells can also metastasize to distant organs throughout the body. Two of its favorite places are the central nervous system and the testicles. Meningeal involvement of acute lymphoblastic leukemia can cause headaches, while metastasis to the testicles will produce a testicular mass. Treatment is with chemotherapy, and in some cases, bone marrow transplant. Fortunately, the prognosis for children is excellent. Let's talk about one form of adult-onset lymphoid leukemia that has a unique pathogenesis. It's called adult T-cell leukemia, and it occurs in the 6th decade of life, as depicted by the wise old knight up on the horse there. Adult T-cell leukemia is actually the result of a viral infection, hence the viral capsid-shaped helmet. The culprit here is the retrovirus human T lymphotropic virus type 1, abbreviated HTLV1. To remind you that this virus likes T cells specifically, we've made the opening to the helmet T-shaped. This form of leukemia is most common in areas where the virus is endemic, such as southern Japan. You can think of HTLV1 as the reverse of HIV, since infection with HTLV1 results in uncontrolled proliferation of mature CD4 helper T cells. At Sketchy, helper T cells are symbolized by helper squires. Adult T-cell leukemia will be positive for the CD4 marker and negative for TDT, since these malignant cells are mature and not lymphoblasts. TDT is for lymphoblasts only. Adult T-cell leukemia presents in a similar fashion to acute lymphoblastic leukemia, with an elevated white blood cell count characteristic of all that T-cell proliferation, and cytopenias of the other cell lines, resulting in normocytic anemia, thrombocytopenia, and neutropenia. Generalized lymphadenopathy and hepatosplenomegaly can also result from infiltration of those organs by leukemic cells. Here's the thing though. Even though there are tons and tons of CD4 helper T cells floating around, very few of them are actually functional, resulting in a functionally immunocompromised state. Therefore, despite HTLV1 being like a reverse HIV, the clinical result is actually the same. since affected patients are at risk for opportunistic infections, just like patients with HIV and AIDS. Adult T-cell leukemia is also notorious for infiltrating the skin, resulting in skin lesions that are similar to those seen in cutaneous T-cell lymphoma, also called mycosis fungoides, with itchy red plaques and papules that resemble fungal infections appearing all over the body. Check out our non-Hodgkin lymphoma sketch for more details on mycosis fungoides. Just remember that this old white knight has accumulated some pretty extensive scarring over the years, though it's the scars you can't see that still haunt him. No, he still has all his man bits. I meant emotional. Last little fact about this weird adult T-cell leukemia thing. It likes to infiltrate the bones, resulting in hypercalcemia from the lytic bone lesions. Yes, nothing a little hypercalcemic milk can't fix. The pre-battle drink of champions. It's like taking a swig of sweet, sweet nectar from the teat of Nike herself. Treatment of adult T-cell leukemia is with chemotherapy. Unfortunately, antiretrovirals don't work against HTLV-1. Despite aggressive treatment, prognosis for patients with this type of leukemia is poor. All right. That's it for the acute lymphoid leukemias and lymphomas. Let's focus on the chronic version now, which includes both chronic lymphocytic leukemia and hairy cell leukemia. We'll start with the more common of the two, chronic lymphocytic leukemia, or CLL. First of all, notice that we're calling this a lymphocytic leukemia, not lymphoblastic. Yep, we've moved beyond the blast phase. CLL is characterized by the abnormal proliferation of mature lymphocytes, specifically B lymphocytes, as depicted by the assembly of mature B-cell archers on the tapestry. As we discussed, B cells are derived from and begin to mature in the bone marrow. So, yet again, we've got a bone marrow problem. That's why the border of the tapestry is subtly bone-shaped. And you know what? It's time to draw in the king himself. Here to remind you that CLL ain't for kiddies. CLL occurs in older adults, primarily over the age of 60. And it's the most common cause of leukemia in the Western world. Let that chronically old clock up there, our recurring symbol for chronic disease, remind you that this whole process follows an indolent course, with a slow, progressive accumulation of mature but functionally abnormal B cells in the bone marrow and peripheral circulation. The prophecy of the tapestry was correct. Mature B cells, an army of bone marrow invasion from the north. Hold the door. It all makes sense now. The pathogenesis of CLL involves a B cell at some intermediate stage between pre-B cell and mature B cell. This precursor gains a few mutations, and before you know it, the bone marrow becomes a monoclonal B cell producing factory. Yep, these cells are just a bunch of clones at first. A slowly encroaching clone of army-mutated B cells, with mature morphologic features. Over time, more and more mutations start to accumulate, and the disease becomes much more aggressive and resistant to treatment. It's thought that increased tumor cell survival, not just increased cell proliferation, plays a big role here as well. It's been shown that CLL cells have high levels of BCL2, a protein that inhibits apoptosis and prolongs cell survival. Scary thought, right? These mutant B cells are like undead, immortal zombies. Though, in reality, cell proliferation and survival rates vary significantly between patients. Nevertheless, to symbolize upregulated BCL2, we have Sean here, holding a BCL2 bracelet, sent along with the message in order to prove the sender's identity. Eventually, the bone marrow of a patient with CLL will become almost completely replaced by neoplastic B cells. When you take that bone marrow sample, remember that these are mature B cells, so expect only a small portion of them to be blasts, usually less than 10%. It should come as no surprise that CLL cells express the usual B cell markers, usually some kind of combination of CD19, CD20, and CD23, with CD21 and CD24 less commonly expressed. To convey the idea of CD19 and higher, we have the king of Whitwakers himself, raised above the rest of his army, brandishing the number 19. Here's a weird one, though. CLL cells can also express CD5, which is usually a T-cell marker. What? These mutant cells are really trying to trick you into thinking they're mature. And they can even express some surface immunoglobulin chains, which, under normal circumstances, would have been part of the B-cell receptor complex. All right, all this talk about bone marrow. What's happening in the periphery? Around 5 to 10% of patients with CLL present with the usual constitutional symptoms, such as fevers, weight loss, night sweats, and fatigue. Remember our tired chef out there? CLL has such an indolent course, however, that most patients feel completely fine at presentation and report no symptoms. They're in your office, just getting some routine blood labs. But then you notice something on their lab results. A high white count. Mostly B cells, in fact. Usually, the threshold to look out for is a B lymphocyte count over 5,000 cells per microliter. But patients can have counts that are much greater, sometimes over 100,000. Take a look at the peripheral blood smear. You should see lots of small but mature-appearing B cells. Another classic finding is the presence of so-called smudge cells, fragile tumor cells that collapse on preparation of the peripheral blood smear. Now, I've said it before, and I'll say it again. Leukemias like to act like lymphomas. Lymphomas like to act like leukemias. It's just a mishmash of lymphs and emias and omas. In simple terms, all this means is that CLL cells aren't just in the marrow and blood. They like to head to the lymph nodes too. A majority of patients, in fact, will present with lymphadenopathy on physical examination. And just like we saw in ALL, hepatomegaly and splenomegaly are frequent findings as well, caused by CLL cells taking over lymphoid tissue throughout the body. CLL can even present as a lymph node tumor, a lymphoma in other words, depicted by our recurring symbol for lymph node involvement, a chessboard loaded with B-cell archers. This special type of lymphoma is called small lymphocytic lymphoma, or SLL. Small just means that these lymphocytes are mature. On histology, affected lymph nodes will show sheets of small B cells, as depicted by the small chess pieces taking over the board. SLL is a pretty uncommon lymphoma, so don't lose too much sleep over it. Just remember that CLL, a leukemia, can sometimes present as SLL, a lymphoma. Regardless of where the initial tumor cells are found, however, just keep in mind the distinctive morphological and molecular characteristics of chronic leukemia cells. That's how you'll make the diagnosis. Now, even though we have all these mature B cells running around the body, don't expect them to act normally. Not only are these mutant leukemic cells non-functional, they suppress the function of the normal B cells still present in the body. See how that mutant B cell is taking down that normal one? Some kind of outstretched death hug. Well, notice that all his antibody arrows are scattered to the ground. Inhibition of B cell function leads to decreased production of immunoglobulins, and therefore low levels of immunoglobulin in the blood. This is called hypogammaglobulinemia. Usually all three immunoglobulin classes, IgA, IgG, IgM, are decreased, and this predisposes the patient to some major bacterial infections. So watch out. Paradoxically, these remaining functional B cells can start producing autoantibodies too. Gah! These autoantibodies can lead to cytopenias, most often immune-mediated anemia and thrombocytopenia. So we've brought in the royal hors d'oeuvres, with little antibody toothpicks symbolizing autoimmune destruction of RBCs and platelets. The empty pan is meant to remind you of pancytopenia. And if you put the whole picture together, it's easy to see why. You might have autoantibodies attacking RBCs and platelets. The enlarged spleen can sequester even more RBCs and platelets. And when enough of the bone marrow is taken over by those mutated CLL cells, all the cell lines go down, just like in the acute leukemias. Remember, it's not technically a pancytopenia, as that white count can be sky high, but don't let those non-functional CLL cells fool you. If enough of the marrow is taken over, all the normal functional cells in the body will drop off. All right, overall, the course and prognosis of CLL can be variable. Many patients will live for more than 10 years after being diagnosed. Though, as time passes, CLL can transform into more aggressive tumors such as prolymphocytic leukemia or diffuse large B-cell lymphoma, both of which decrease survival considerably. Okay, time to finish up the sketch with our last chronic lymphoid leukemia, the aptly named hairy cell leukemia. Hairy cell leukemia is a chronic B-cell neoplasm that occurs predominantly in middle-aged men. So we've hung another tapestry on the wall, this time depicting a middle-aged hunter with a B-cell bow. Hairy cell leukemia gets its name because the neoplastic cells have characteristic fine hair-like cytoplasmic projections. Akin to bear fur, maybe? Just hang with me here. These hairy cells also stain positively for tartrate-resistant acid phosphatase, abbreviated TRAP. There you go. A bear trap. See? I knew you'd like that one. Hairy cell leukemia likes to infiltrate the reticuloendothelial system, causing characteristic massive splenomegaly, which may cross the midline or extend into the left lower quadrant. I mean, just look at the size of that spleen-shaped sac and fit a whole bear in there. As the hairy cells fill up the bone marrow, they cause fibrosis and failure of the bone marrow, leading to pancytopenia. So, we've included the fibrotic bone tree, along with our recurring pancytopenia pan symbol. Obviously, the bear took the bait. Due to extensive fibrosis, bone marrow biopsy may not return any contents. This is called a dry tap, and is symbolized here by the empty bone cup. Bears just can't resist an icy cold beverage. Works every time. Fortunately, hairy cell leukemia is responsive to chemotherapy and prognosis is generally good. The treatment of choice is usually a purine analog, such as cladribine or pentostatin. Just imagine our caveman from Sketchy Farm clad in bear fur. That's clad for cladribine. Phew, that sketch was extensive. Nothing a quick summary can't fix. Lymphoid neoplasms are B and T cell cancers. Acute is out in the courtyard, while chronic is up in the castle. B-cell acute lymphoid leukemia lymphoma is caused by a mutation in a pre-B cell in the marrow. That's where B cells are born. T-cell acute lymphoid leukemia lymphoma is caused by a mutated pre-T cell in the thymus, where T cells mature. In the acute lymphoid leukemia lymphomas, the characteristic progenitor cell is the lymphoblast. They're large-ish with purplish nuclei. No granules and no hour rods. That's AML. They are PAS positive, though, if that helps, as well as TDT positive. If it's a T-cell-derived neoplasm, look for CD markers that are less than 10. If it's B-cell-derived, look for CD markers 10 and higher. Mutated B lymphoblasts like to cause the leukemic form of disease. That means over 25% of the marrow is involved, causing neoplastic cells to fill the circulation. Remember, you may have a high white count, but those are just all those blasts. With extensive bone marrow invasion, your patient will likely suffer from a functional pancytopenia. As more lymphatic organs get taken over, look for hepatosplenomegaly and lymphadenopathy as well. Maybe some bone pain. Mutated T-cell lymphoblasts like to form lymphomas rather than leukemias. That means a mass outside the marrow. You might even find a mediastinal mass. Compare all this with the chronic version, CLL. It's slow, it's indolent. ALL was in kids, while CLL commonly affects patients over 60. CLL is caused by a mutated B cell in the bone marrow. This time it's more mature. Look for mature cell markers like CD19, 20, and 23. CD5 too, which is weird. Mature monoclonal B cells start to take over the marrow and leak out into the serum, usually causing a white count above 5,000. On the smear, look for smudge cells and lots of mature B lymphocytes. And it's not just the blood. CLL takes over the lymphatic tissues, leading to lymphadenopathy and hepatosplenomegaly. CLL cells don't work very well, and they even inhibit any normal B cells that are still around. This can manifest as hypogammaglobulinemia, a lack of antibodies, in other words. Or B cells can start producing autoantibodies, which can take down various cell lines. And don't forget about hairy. Hairy cell is, well, hairy, of course, but it's also TRAP positive and likes to take over the bone marrow and cause myelofibrosis. Well, after talking about it so much, winter is finally here. That wasn't unnecessarily drawn out or anything. Some of those middle parts especially. Could have done without those. It's a bit nippy out here. So let's head inside, shall we? If the whole EMEA versus OMA thing wasn't already confusing enough, get excited for some more OMAs.